Okay, so let's talk about respiratory. I can't tell you how many times I've given patients this look, because one thing that, like chest pain, we rate it on a scale of 1 to 10. Respiratory emergencies, a lot of times we rate the severity on the number of words they can say before they have to take a breath. Okay, so that patient, I can talk about 100 words per minute. Someone timed me before without taking a breath, and but this respiratory patient usually will start to breathe like this, and they'll be very sort of have to take a breath about every other word, right? That's one sign of severe respiratory distress on how many words they can say in between each breath. But if they won't stop talking, if they're just like this, 100 miles an hour, they're not really having any respiratory problems, okay? Because they can get a lot of air in because they keep on talking, right? So that's this thing. This we will get back to in a while, okay? This is the I think you watched this video, perhaps maybe, about the brainstem and different functions. But we talked about the pneumotaxic center, where you have the apneustic center, the centers, respiratory centers on the pons that control inhalation and exhalation. Anyway, this is for another day when we talk about that in these pacemaker cells. The problem that happens with respiratory emergencies is what's called a VQ mismatch. And just like it says, anything that increases or decreases ventilation to the lungs or perfusion to the lungs, right? So ventilation, air that goes in and out, right? So anything that decreases us from getting air in or out, which is the V, ventilation, okay? And then the Q stands for perfusion. What level does this happen at? The perfusion. Right, alveoli. So this happens where gas exchange on the perfusion part. So any problem getting air in or any problem with gas exchange, and then which would cause a VQ mismatch, ventilation perfusion mismatch, is the problem, and that's what we're going to look at. Right? Here's some of sort of a quick reference. This is a normal, see, good normal blood flow here, nothing here, okay? This picture here, you have a shunt of the airway and then a dead space. We have dead space air. I think don't quote me on the number, but I think it's about 150 milliliters of air. So that normal tidal volume, which is what? 500 milliliters in, we lose about 150 milliliters due to dead air space, meaning that the space between the mouth and the alveolus, right? That tube, you lose air through there. Okay, the same way that you would with the hose, it decreases pressure in a sense. The way that as it goes through there, we lose air. We have dead air space, which meaning that air doesn't get to the alveolus to diffuse across. Okay, there's a lot of other reasons why we would lose that. Body temperature is one of them. Increased body temperature. We have more dead air space. We lose ventilation. I can't remember the number that actually gets down to there, but it's not 500. You don't breathe in 500 and 500 gets to the alveolus for diffusion. You lose quite a bit of it, most of it. Okay, just like exhalation. 16% air, right? So we only use 5% of it. So I don't know how the math would correspond, but I don't know the number of actually it gets down there. Maybe I'll look it up one day. So before we can determine if the patient has some sort of respiratory problem, we need to understand adequate, right? Are they adequately breathing? Okay, there's no obvious distress. Okay, I see nobody in here that's having trouble breathing. Okay, maybe holding your breakfast down but not having trouble breathing. Okay, speak in full sentences. No hesitation there. Warm, pink, dry. ANO times 4, right? Everybody's here has that. So adequately breathing. You have a good rise and fall of the chest. Okay, you're getting good tidal volume. So there's a lot of things that go into it. Is the patient getting good tidal volume? Do they have symmetrical rise and fall of the chest? Is there some sort of blockage? Do they have a wheeze there? All right? Do they have a lot of mucus there? Can you hear that? Are they pale? Are they flushed? These different signs. So here, this would be adequate. So okay, so we think we got what's adequate. The quality and the rate. Are they 12 to 20 times per minute? Remember, we breathe about 14 to 16 times per minute at a resting rate. 20 is actually a little fast. So, do they have a good rhythm to it? Good quality? Good amount of chest rise and fall? Do they look like they're having trouble breathing? Right? That good general first impression. Do they look like they're having trouble breathing? Right? You'll be able to see that. Is it a regular rate? Do we have good equal present breath sounds? Now we go to the other one, which is subjective. Okay, remember, I'm having trouble. If the chief complaint is I'm having trouble breathing, right? That's a sign. It can't be measured or observed. It can be observed a little, but it's more of a symptom, right? Because it is subjective when we look at it. So does it feel like I'm having trouble breathing, or do I have to work to breathe? Okay, the difference is if we took someone that wasn't athletic and ran them up and down the stairs, okay, then after a few times you would see work of breathing, increased work of breathing. They're having to work to breathe, okay? They're just not having difficulty breathing. There is a separation there. The treatment's really the same for the most part, okay? And does their distress, they're saying just like this person, pain is really subjective. So you have those people who, it's a 10 over a 10, but they're talking to you normally. They don't look like they're in any sort of pain, right? So your general impression is you don't look like you're in pain. I can't tell you how many times I've said that. You say 10 over 10, but you don't look like you're in pain. I'm in terrible pain. But you don't look like it. Just like you don't look, if you're saying 1,000 words a minute, you don't look like you're having trouble breathing. So that general impression is very important. All right? We still do our OPQRST, our sample. We do a good assessment. All right? When did this begin? What were you doing when you started having trouble breathing? Okay, that's important. What took place here? Okay, do you have a cough? See, on your assessment questions that you were giving, these were broken down. Do you have a cough? Is something coming up with that? Are you having trouble breathing, trouble getting a deep breath, and then you're hacking up these nice raw egg-looking loogies? Little blood tinged in there. You just cough and you go, it's like, wow, that thing's alive. It has a pulse. It's vibrating, If you're coughing that up, you probably need an antibiotic, okay? But are they productive, or is it a dry cough? Remember, a cough is a reflex that we have to get irritants out of the lungs or out of the airway. Right? Do you hurt anywhere else? Do you have any discomfort? In what I use, instead of that 1 to 10 scale, I say words per breath. So if they're talking like this, they're 1 or 2 words per breath, then that's a sign that they have severe respiratory distress, perhaps. Okay. And then how long? How long you've had this feeling that you were having trouble breathing? Okay. So we do the same scale, just a little bit different question, sort of to tailor it to the emergency. All right. Do they have altered mental status? You know, person, place, time, event. Is there some sort of altered mental status there because of hypoxia, right? They're not getting enough oxygen to the brain cells. They become hypoxic. We'll talk about this barrel chest thing here in a minute. Okay, that's important. These characteristics of these people with COPDs. Okay, you can pick them out from Walmart. We'll do that too, by the way. Chronic obstructive pulmonary disease. Chronic means over time, right? So over time, these guys here with emphysema, due to hyperinflation, it stretches that chest wall out, and they look like they have this barrel chest. You can see them. You can stand there watching people come in the door, go emphysema. Gets you a bad emphysema, you're on oxygen. You know, chronic bronchitis. No toes or feet, you're diabetic. You know, they lose diabetics, they get their non-compliant diabetics, they lose their toes and their feet and their legs. Okay? So, you must have chronic bronchitis, you're overweight and sweaty, you know, and gray looking. So you can pick them out a lot of times, and not that you won't make fun of them or anything, but you can definitely pick them out. Or they tripoded. A tripod is sort of an autonomic thing where they're bent over, right? They bend over, they're like this, and they're trying to get air into their lungs. So they're bent over, they're tripod. The two legs are one pod, and the tries where they get the thing, you know, here. Put your legs together, tripod. Make sense? It increases the amount of surface area in the lungs, helps to get more air in. Okay? So they do this tripod. They may want to sit up straight. They don't want to lean back or anything. Sit upright. Retractions. Retractions come in the neck, where they start pulling on their neck. You see the retractions in their neck here. Okay? Nasal flaring. Their nares will open up and flare out so they can, all in the attempt to get more air in. The pursed lips we'll talk about in detail a little bit more with the picture, but this essentially offers some PEEP for them. Positive end expiratory pressure. What pursed lips do is the PEEP, not like the peeper, you know, but huh? Well, they purse their lips like you guys take your pictures now. I don't understand why you do it, but anyway. Positive end, END, okay? Expiratory pressure. Positive end expiratory pressure. They do this on a ventilator where they add PEEP, and what it does is it helps with the pursed lips. It helps keep that alveolus open more, okay? Because we're about to talk about it. What transpires here is not getting air in; it's getting air out, air trapping. So this sort of, you watched the video, right? The door. Yeah. It leaves the door open more. That's a good analogy. It opens that door and leaves it open more, so more air can get out. All right? Positive end expiratory pressure. So the pursed lips adds some PEEP to it. Why do they do that?
Oh, the lips?
Yeah.
The lips? Oh, for the picture? Like they,
So their cheeks don't look as fat, probably. Oh, okay. Bend your face down. Yeah. Okay.
That's cute. It's cute.
What I'm not really saying one way or the other. I'm just saying Okay, that's something, it's not really new, though, is it? It's just one of those things. Anyhow, and then the number of words you're saying without stopping as well. One thing that they will do also is called belly breathing. Normal respirations, we don't use our abdominal muscles to breathe that much unless you're singing or shouting or something. Then you use the abdominal muscles. You pull the abdominal muscles in to shout, but or to sing. It helps with this. This is an example of belly breathing. This guy, let me take his video. He's not dying. Well, he is, but he's So you hear the grunting and see the belly moving, the abdomen moving. Once you see that, and you don't really have to be in medicine to see that and know that. You could be a lawyer and go, I think that guy's having trouble breathing. Right? Yeah, he's having trouble breathing. See, so a good general impression. Other observations, are they cyanotic, which is a late sign, right? Flushed, sort of a red. We'll talk about that red appearance. Remember the hypercarbic person, sort of retaining that CO2. They fail to have pedal edema. We talked about that. Sacral edema, where's that at? The lower back, right? They have this coughing. Is it a dry cough? Is it a wet cough? Are they coughing anything up? Is it productive? Productive cough means that it's coming out, right? A dry cough, it means that it's dry. There's nothing coming out. Okay? It's non-productive. So we use our observation skills. Do they have an audible wheeze? We can make Steve audible wheeze. You can hear it without the stethoscope. You can hear the person wheezing without the stethoscope. That's caused by that bronchial constriction. Okay? Gurgling, fluid, right? Snoring respirations. There's a stridor, which is an upper airway sound. That way it's this harsh upper airway sound. It's a sign of a partial obstruction. Crowing is something that pediatric patients do, sort of a movement back and forth, just try to get more air. All this is to try to get more air in, okay? Or due to some sort of constriction. So we'll take the time, we'll listen to these different airway sounds, get familiar with them. And when you go to auscultate the airway, your breath sounds, try to do it on the back. You actually lose quite a bit of sound anterior. It's best to listen posterior if you can. Steve, his speakers are in the anterior, so that's the only place you can listen. Okay, but try to listen posterior. So you listen. You compare one side to the other side, then you would listen down at the bases and compare one side to the other side. So this high-pitched sound, it's a narrow passage, it causes constriction. Fluid can also cause constriction. We just talked about crackles and rhonchi, right? Okay, and then stridor, this high-pitched sort of upper airway, it sounds like these Germans talking. You see them on TV, and all of a sudden they're really harsh sound, like they're just about to spit up a loogie, They're going, there's a bluebell. That sort of harsh airway sound that they have. Sort of a little bit of an obstruction there. We're back to this SpO2, right? Increased respiration is going to mean increased heart rate. Make sure that the pulse that's on your SpO2, your pulse ox, that correlates with the mechanical pulse that you feel, and then evaluate the need for oxygen, right? And we've talked about this before. The need for oxygen is respiratory signs that they're having difficulty breathing, right? Retractions, belly breathing, any of those things, nasal flaring, tripod, any of those would be, yes, they need oxygen, right? And then, what's the number that we cut off at? Right, 94%. Or if their SpO2 is less than 94%, we give them oxygen. If they're having no outward signs of respiratory difficulty, none of those signs we just talked about, okay, and their SpO2 is greater than 94, no need for oxygen, okay? So, when I say evaluate the need for oxygen, that's what we look at. Then if we do, we give them oxygen based on their need, right? If they're a mouth breather, then they need a mask, correct? If they're just having mild respiratory distress, then you could put them on what? Very good. Nasal cannula. What liter flow? 2 to 6. Good. So nasal cannula. If they're a mouth breather and they're using retractions and belly breathing, what then? What device would you use? Non-rebreather. What liter flow? 10-15 liters. Okay. If they're really bad, they could do what CPAP, continuous positive airway pressure. You may have already seen this. I'll pass the mask around. CPAP is great because, don't worry, I used it for Halloween, so it's a little, but can you imagine? Trick or treat. They're like, here's all my candy, get out of here. But it fits on the patient's back of the head like this. Have y'all seen this yet? Somebody on CPAP? It may be called, they may be on BiPAP in the hospital, but CPAP is continuous positive airway pressure. BiPAP uses the patient's respiration as breathing pattern as well, so it alternates. But the CPAP continuous, so it continuously forces air down into the lungs. Okay, what this has done is it saves patients from being intubated so fast. Because if I pick that patient up, that emphysema patient up, and they're having trouble breathing, they're having retractions, and they're sort of wearing out, you know. I mean, they're really having an increased work in breathing, and you know that's going to put increased workload on the heart as well. So I may elect to go ahead and intubate that patient. Okay, well, and this was, you know, back in the day, okay, before CPAP. The problem with intubating that patient is that they have trouble getting off of the ventilator. So that emphysema patient, that asthmatic, that chronic bronchitis patient, you put them on a ventilator, they have trouble getting off, weaning them off the vent. So that's a problem. So when they came up with CPAP, they use CPAP before they intubate the patient to try to keep them off the vent. Okay, they'd much rather have this mask on my face than a tube in my throat, right? So this helps out quite a bit. They turn it up according to this gauge here. Okay, they usually they start out about 10 centimeters of water, so it takes about 10. It takes quite a few liter flows. You just turn the liter flow up till you get about 10 centimeters of water is what it's measured in here. Okay, just a measurement. And then strap it tight like a bag valve mask over the patient's face. So CPAP is a great thing. It keeps these patients from being intubated. This is something that you will get with respiratory on as you go through your rotations, okay? So that's one treatment. We determine the need for oxygen. Then we look at CPAP. We'll talk about albuterol, albuterol in a minute, and Atrovent. But those are another couple treatments. And we look at nice big healthy lung. Okay. This person smoked. What about all these little things here? Those brown spots on this healthy lung. Huh? That's from, what do you think that's from? Any guesses? Smoking. Any guesses about those little spots?
No.
That's from enjoying your day outside playing golf. This is pollution. Right? So, if you live in India, you would have a lot of those. The air quality is horrible, okay? In places, right? Because it's so populated. But anyhow, so smoker lung. I mean, we held one of those, right? You picked one of these up, little note there. Nice, healthy lungs. Cigarette smoking. If you haven't started smoking, don't start vaping. So you need to stop smoking. I know you're in the closet. Right? Spray like parents can't smell that. Go outside, run around the portable. 3 minutes. So
do people who smoke weed, do they lungs like that too?
yeah, this smoke weed.
Do they lungs like that too?
We'd smoke anything.
Oh, yikes.
You'd have to smoke a lot of weed. But same as cigarettes, you get the smoke in there. Smoke, right? Yeah. So emphysema. Let's talk about this right quick. This will be the first medical emergency or the first COPD that we'll speak of. Okay. So it breaks down the walls of the alveolus, reduces surface area, reduces the elasticity of the lungs. Okay, does all these things. When a person is smoking, they smoke all the time. It's not if they contract emphysema, it's when. It's well proven by the American Heart Association that smoking is a direct link to emphysema. Now you're here, people. I've smoked for 50 years. I breathe good. I do all this, so it's not 100%. It's like anything, right? But most people come down with emphysema. Patients that have never smoked in their life can come down with emphysema. If they work in a job field that they should be wearing a respirator and they don't protect their airway, like paint and chemicals and stuff, they can come down with emphysema as well.
Is it a process that builds up to it?
Yes, it's chronic. Yeah, it's a process that they build up to. And it's an obstructive pulmonary disease. Oh.
Well, sometimes doctors make mistakes, and they need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Yeah. Oh, you laugh. But there's that person just like that. Yeah, you laugh. I've met that person. Okay. So let's look at review our normal values right quick. Okay. Yeah. So normal PO2 is 80 to 100. We haven't talked about PO2 yet, but PO2 is the percentage of oxygen in arterial blood. So it's 80 to 100. Remember, SPO2 is the partial pressure of oxygen in a capillary bed, right? So PO2 is percent of oxygen in arterial blood. This is for another day. We'll come back to that. PCO2 is 35 to 45. Bicarbonate, bicarbonate's like a big Tums. Okay, it controls in the buffer system. It controls the acidity of the blood. So we have what's called a buffer system. So if the blood becomes acidic, the body will release bicarbonate in order to maintain homeostasis. Alright, so the normal bicarbonate level is 22 to 28, and then the blood pH 7.35 to 7.45. And this pH is just a measure of hydrogen ion concentration or acidity, right? So if we look at anything below 7.35, that's acid. Above 7.45, that's an alkaline, right? So you have acidosis and then alkalosis on each side of it. Okay. And we'll get into a bit of that as we work through this. I have no idea why I put that up there. That's something we were talking about at the time. How you will see this is in an arterial blood gas. So if you're doing your rotations with respiratory, they may go do an arterial blood gas where they'll stick a needle in this person's artery and draw arterial blood, okay, to look at their blood gas. I think I have a little picture of this that the respiratory therapist gave me on a patient that we were looking at. So you look at the pH, 6.85, right? I mean, they're real acidic, okay? PCO2, they're real acidic. Look at that, 69.9, almost 70%. At some point in time, and the people you ask, they vary their explanation of this, but a person can become so acidic that it's incompatible with life. Okay? This is very close to being incompatible with life. But you look at the PO2, 34. Right? It's supposed to be, the minimum is 80, right? So there's a big problem in this arterial blood gas. That's why he gave it to me, so I could take a picture of it and have you guys look. So as you go through your respiratory rotations, take note of the arterial blood gas. Ask them about it. Have them show you the values and how that is all configured. And later down the road, we'll get back to ABGs as well. We'll talk about that, okay? So this is a big, I wrote this down the other day and just put it up here so I didn't have to rewrite it again. But the COPDs up here, chronic obstructive pulmonary diseases, right? It's an expiratory problem, not an inspiratory problem. Normally we breathe on negative pressure, right? The pleura is pulling the bronchioles open, which creates a negative pressure. You guys are a little bit more fortunate than the other class because you watched the videos, and we did this before the video assignments were due. So you have a little bit more working knowledge of what we're going to look at. But this picture here is a normal. See how normally this looks familiar to you, correct? Yeah. So you have this nice open airway, right? This nice open alveolus. But what happens here is because of this mucus production, okay, now we have some obstruction here, correct? And then the tethering effect. So here's the lung and here's the pleura. And it pulls that open, okay? The pleura, this tethering effect, because of the elastin, okay, pulls the airway open, right? Sound familiar? So it pulls this airway open in order to get air in and out. But in an emphysema patient, one of the problems is this overproduction of mucus. We normally produce what?
1
liter. Liter. All the time. There's always mucus in the airway. But one thing that smoking does with this emphysema patient, right, kills the cilia. I don't even have to talk about this. Kills the cilia, right? The cilia, these little airway things, they move and they move all those irritants up and out of the airway. Okay? Well, it kills those. So now you don't have that. You don't have that cilia working, picking those irritants up, getting rid of that mucus. Right? So it stays up. Plus, it causes over-secretion of the goblet cells, because the goblet cells help produce the mucus. So now you have a problem here that you don't have a way to get rid of the mucus except to cough it up, okay? And then they overproduce the mucus. So you have a mucus problem. This big word down here, this mucus clearing, mucociliac clearance, means you don't have enough room to get the mucus out, right? So you have that smoking patient, okay, just like my dad did every morning. He woke up, he smoked all the time. He always had a cigarette in his mouth, okay? So he woke up in the morning and he would hack and cough until the point where he was drooling and he would turn red and water coming out of his eyes, and he'd cough and cough and cough because he'd spent all night on his back or side and he had all that mucus built up. So he had to get all that stuff out, right? I left. You know, I was like, I'm out of here. You die again. Oh well. You know, but so had to get all that mucus out of there. All right. And the other thing that it does is it destroys the elastin. Huh?
It's right here.
Oh, good. Lose my Easter eggs. So we back up here, and what happens is, through this process, the elastin is destroyed by the elastase. Okay? The elastase is produced by the inflammation. Okay? It causes inflammation. The elastase causes inflammation, causes the release of neutrophils, which is just white blood cells. Okay? And then it produces the elastase. Okay? We have the inflammation due to the irritants in the mucus in these goblet cells, like we just talked about, this overproduction of mucus. All right? And so we're dependent upon this elastin because of the tethering effect of it. All right? It's like a rubber band. So we're dependent upon that airway being tethered, being pulled open and allowing it to close somewhat, not close totally, but you open it and keeps it open to get air out, correct? Like I said, it's not a problem getting air in, it's a problem getting air out. Air trapping becomes the problem. And it's through this process here, because the loss of the structure, okay, the bronchioles, and this goes back to the video, right? The bronchioles should look like a balloon. I mean, the alveolus should look like a balloon, correct? Instead, they look out like this plastic bag. They flatten out. So it's just due to the destruction of this elastin, and it damages this tethering effect that we have here. So this part right here is affected by that, and then you get this flattened out alveolus here, so air can come in, all right, but it can't get out. But the process still takes place, right? Carbon dioxide diffuses back across, oxygen's coming in. That process doesn't stop. So what else gets trapped there? CO2, right? Bad gas, real bad gas, like bad, worse than burrito gas. CO2. I had a little gas here. I'll just wait here, okay? You okay with that? You won't talk bad about it? Okay. Anyhow, so we get air trapping because of that flattened out alveolus. Right? So we can't get air diffused, okay? And we can't get CO2 out. So you start to sort of see the problem with this, and then they're having trouble breathing, so they're really trying to hyperinflate the lungs to get more air in, and we just keep trapping it, so you have a buildup in CO2. So these patients become hypercarbic. So back to the video picture here, right? You have this sort of flattened out alveolus, you have the obstruction with the mucus and everything, this barreled chest, okay? With this guy here, this emphysema patient, you're going to have the pursed lips. There's a slang term that we really don't use, but we call them pink puffers, okay? Because of the redness in their skin, they're usually retention there, okay? And then they have the pursed lips, offering the peak, right? Positive in expiratory pressure. So they create this peak to keep this door open longer, to get air out. That's sort of a mechanism that they do to sort of help them there, and it helps with sort of slows the respirations down somewhat. Okay. Any questions over that? I mean, the video probably explained it a lot better than I did. So, anyhow, it is an obstructive problem. Overinflation, pursed lips, helps them to breathe slow, to get the air out. Pink puffer, the CO2. Now, they disagreed with this on the video, correct? Y'all remember that about the redness of the skin? What did they say about the redness of the skin causing that flushed look in the emphysema patient?
Excessive CO2.
Oh, did they? Never mind then. I thought they disagreed with that. Okay. So, excessive CO2. Okay, let's go with that, right? I don't know where I heard that from then. So you have this process here that is chronic, and it sort of spirals out of control, right? The more they smoke, the more these things take place, the more problems that they have with the problems with emphysema. Okay, so the chronic bronchitis patient. Everybody okay with emphysema?
Yeah.
You got the sort of the physiology behind it? Okay. The thing with chronic bronchitis patients is that it's not a problem with destruction. I think I had that on my thing. Yeah. It's not a problem with destruction. Emphysema destroys the elastin, destroys the cilia, right? Makes it stop working. The problem with chronic bronchitis patient is it's what's the word? Hang on. Old moment. Not destruction, but obstruction. So they create this mucus production. It causes really overproduction of mucus with the chronic bronchitis patient. Okay, bronchitis. Has anybody ever had bronchitis? Yeah, well, you probably had it. They probably called it an upper respiratory infection, but they mean bronchitis, right? So we get bronchitis. Hopefully not anytime soon. And then we take antibiotics for it, it clears up, and it takes about 3 weeks to really, where you can speak 100 words per minute. But we had short classes back then. I had it before, and it's like, okay, are there any questions? Good. You know? But, so, over time though, they build up this chronic mucus production. The mucus creates all these irritants in there. They get the infection over months and years. One difference is the fever. This chronic bronchitis patient will have a temperature associated with it. Emphysema patients don't. They always have that because of destruction. This is obstruction, so they build up this mucus over time. They are called, because of this grayish look they have, the slang term is the blue bloaters. Of course, we don't really use that, right? We don't call our patients vegetables, or we don't call them pink puffers either. So, but blue bloaters, because they get this sort of grayish look to them, almost cyanotic, but grayish. And then in my experience, they've all been overweight. They're little fatties, okay? And they all sweat. They're all real sweaty. That's my thing with chronic bronchitis patients. And they produce a lot of mucus. They're always coughing up stuff, okay? So that's the difference between emphysema and chronic bronchitis, okay? Now, the good thing for us at where we are, that at our learning level, okay, the treatment's the same. Okay, so we take this emphysema patient or this chronic bronchitis patient, we determine the need for oxygen, all right? Then we give them a beta-2 agonist, which is a bronchodilator, albuterol or Ventolin, depends on, I just usually call it albuterol. If you spell by phonics, it's albuterol. But albuterol, it's the class of drug is a bronchodilator, but it's a beta-2 agonist. An agonist helps, right? An antagonist is against, correct? So we get this beta-2 agonist, and it's a bronchodilator, and it's given, like you've seen on the video. Any wheezers in here? Asthmatics? No? Yeah, but you take this, a meter dose inhaler, okay? So, or an inhaler, right? So you start having a little asthma attack or whatever, or trouble breathing. Even with bronchitis, they'll give you one of these to breathe on, okay? And you take it and you, right? And so what you have to do, and it's the same process with the nebulized treatment, okay? You take it and you have to sort of coach the patient because the patient's having trouble breathing, right? So their respiratory rate is up. This is a powder. So that you do one of those numbers, okay, and you tell the patient take a big breath, squeeze in, hit the nebulizer so the medicine go in, big breath, and hold your breath. Okay? The medicine has to get down to the bronchioles, right? If that patient goes, the powder it got here and went back out, right? The same thing with the nebulized treatment. You have to sort of coach them, say, I need you to hold your breath for a little bit, all right? All right? Hold your breath and get that medicine down into the bronchioles. It works the same. It's the same medicine, albuterol in the inhaler, the meter dose inhaler, or the nebulized treatment. Right? This is in powder form. The nebulized treatment is in liquid form. So you give them this bronchodilator to help to dilate those bronchioles, all right? Because they're constricted. You may hear a wheeze, okay? You may hear fluid, which is the mucus. That could be also the cause constriction. But usually you're going to hear a wheeze there, so you bronchodilate it so more air can get through. Just like nitroglycerin, right? You give a nitro pill to do what? Vasodilate, right? Nitroglycerin to vasodilate. So this is the bronchodilate. We give the nitro to vasodilate to get more blood flow around the obstruction. We give albuterol to get more airflow around the obstruction. The obstruction here is usually mucus. So we can do that. So we give the albuterol, which is the class of drug is a bronchodilator. So we get this bronchodilator. We could give Atrovent. Atrovent is the class of drug is actually still a bronchodilator, okay? But the atropine part of this, it's sort of cousins with this other drug. But what Atrovent does is it decreases, it has a drying effect. So it decreases the amount of mucus there. So you have albuterol and Atrovent, okay? And they're given in a nebulizer called an A&A. So they put them all in the same nebulized treatment, right? So they can you can mix them together. So you have albuterol causes the bronchodilation, and Atrovent helps with the drying. Okay, So this would be our essential treatment. In here, I didn't write down, you could give steroids. You'll give steroids because of the inflammation. So you give a steroid over here. The good thing about it too is when we talk about asthma sometime this week, the treatment's the same. So you don't have to learn 3 different treatments. So emphysema, chronic bronchitis, asthma, the treatment's the same. Determine the need for oxygen, okay? Give them a bronchodilator to open those airways up. Atrovent to help dry the secretions. So the treatment's fairly easy. So when we look at the nebulizer, you want to hold that for me? Don't let it fall. So we have if you've been with respiratory already, you may have seen them giving a treatment, a breathing treatment, correct? All right, so you have the nebulized mask. Sometimes they have a little peace pipe they hold out, hold it, but most of them just put the mask on. You take your liquid albuterol. The dose, if you're interested, is 2.5 milligrams in 3 milliliters of water, okay? And all this is disconnected, so you just take it and you connect it all back up, twist just like those little juice things, okay? And then put the medicine in here. Oops, not necessarily on your finger. Okay, there goes a couple milligrams. And yeah, put this here. Okay, we need to turn on our cylinder. Huh? And then we put it up to oxygen. And then what we want to do with a nebulized treatment here is to make it mist, right?
Yeah, it comes out.
So about 6 liters per minute. Do you see the mist?
Oh, yeah.
Coming out. And you put the mask on, and they take a breath out. And again, you want them to hold that in, right? This mist. Try to get it down to the bronchioles. Hold that in. Hold that in. And if you turn it up more than 6, it just mists too much. It looks like a fog going out there, and the patient won't get as much medication. And so they'll just wear this and they'll breathe that in, okay? They'll go ahead and give them the steroids because the steroids take a long time to work. There's 2 properties of the steroid. One that sort of works a little quick. It has a quicker onset, but typically steroids take about 8 hours to work. So they give them the steroid. They're going to start them with the nebulized treatment, get them opened up. Okay, if they're really serious, critical, they may start with the Cpap and then attach this nebulizer to the Cpap and give them this through the Cpap, okay, the mask. Is everybody good with how that would work? And you just put it on there and sort of coach them. See, that's it. See, if you turn it up to 10, see how much more it missed at 10? That's just wasteful. They're not getting all that. It's coming out everywhere. So turn it down to about 6 and just let it miss. Okay? Alright, so you have this respiratory patient, you're trying to tell them to hold their breath, right? They're going to look at you like, you're nuts. I'm having trouble breathing. But they're really no need to do that. They really don't need to hold their breath. Not that you guys would know anything about this, except you. You brought up the pot, so I don't know. Didn't you say, well, you just smoke weed.
Yeah.
Okay, but, so what you do is just like that guy who's smoking pot, let's say this, I got some pot in here, and I'm going to light it up, right? Now, I'm not going to breathe that in. I'm not going to go, right? Because I'm not going to get the effects of the drug. That'd be like Clinton. I didn't inhale. I mean, you know, it'd be like, right? It got to about here, and I blew it back out, correct? So just like that pot smoker, they sit there and they go. So they hold that in there as long as they can. When do they hold it in there as long as they can?
They can get the high.
They get the drug that's in the pot. They get that drug. Same way with albuterol. Hold that in as long as you can so they can get the drug. It's just a pharmaceutical drug here, okay? So they hold that in. It's the same principle. Now they're not going to hold it in any long because they're having trouble breathing. But you coach them into holding at least a second or two, right? So they may need some coaching as far as this is concerned here. You guys have any questions over emphysema? I mean, it was pretty quick, but you guys have got the videos down. You watched quite a few videos over it, so yeah.
Now we
know Too many. But that is the benefit of having that prior knowledge, right? We can shorten this process somewhat. Let me make sure I covered everything. Yeah, you did. Just shut up. You're done.
Can I take a picture of the
Yeah.